Well, good morning, everyone, and welcome to our newest Grand Rounds. And this is a very special day for me, not just as chair of medicine, but because it's a celebration of two people who we actually revere absolutely, and in the field of medicine. First, I'm going to introduce Dr. Nanette Wenger, who has been a mentor of mine for so many years that I don't want to say it out loud, but she's going to be delivering our annual George W. Pedigo Jr. lecture. Dr. George Pedigo was a long-term faculty member at University of Louisville, and the George Pedigo Fellowship Fund was established in 1988 by Louisville natives, Mr. and Mrs. Robert Hooke. The first annual George Pedigo lecture was held in 1988, and it was actually Dr. Edward Hooke who actually was a visiting professor to prevent the first in this long-standing annual series. Dr. Pedigo was a native of Glasgow, Kentucky, and received his medical degree from the University of Louisville in 1938, joined the faculty in 1945, and began training in internal medicine after being in the U.S. Army Corps. He was a former governor of the American College of Physicians and a lifetime member of the University of Louisville Board of Overseers. He was promoted to emeritus professor in 1981 and received Kentucky's first laureate award and was made a master of the university in 1991. He passed away in July of 1999, but is remembered as an avid supporter of the Department of Medicine and an outstanding physician and academician. His numerous publications, all of which were so instructive in terms of pulling medicine more into the modern era. Now, when I was asked to choose someone who would give this very elegant lecture, and as my first choice as chair, there was no one else that I could think of other than Dr. Nanette Wenger. As I mentioned, I was a house staff at Grady Memorial Hospital, part of the Emory University program. And she was the first academician that I spent so much time with once I had my MD. And she really fundamentally changed the way that I thought about medical care, particularly for the underserved. I always said that you can leave Grady Hospital, but Grady Hospital never leaves you. And that was the impact of Dr. Nanette Wenger on my career. She is a professor of medicine, Division of Cardiology at Emory, and her legendary career spans more than 50 years. She's had a steadfast dedication to reducing women's disability and death from cardiovascular disease, and that's made her one of the country's most respected experts on coronary heart disease in women. In 2009, the women's health pioneer that she has been received the Lifetime Achievement Award from the American College of Cardiology. Her association with the ACC spans over a half century, and we have traveled together around the world, giving lectures on prevention and detection of disease in women. She was a native of New York City and a graduate of Hunter College before going to Harvard Medical School. And she received her medical and cardiology training at Mount Sinai Hospital before coming to Emory University and Grady in 1958. Since that time, she really has been a trailblazer and an icon in the field of cardiology, co-author or author of over 1,300 scientific review articles and book chapters. And she has earned dozens of awards in her celebrated career. Perhaps the greatest professional achievement and one that has brought her international recognition was really the major change in the paradigm of cardiology, and that is the getting rid of the assumption that heart disease only affects men. Today, thanks to her pioneering clinical and research efforts, it is known that cardiovascular disease is the number one killer of women in the United States. 38% of all female deaths, which she's going to help us detect and understand today. And it really is much greater than all forms of the cancer combined. And this really, the recognition of this really has to do with Dr. Wenger, her fundamental work. She helped write the 2007 guidelines for preventing cardiovascular disease in women. And with that, she's going to deliver the address today. And the Pedigo lecture will be entitled Cardiovascular Disease in Women, the Epidemiology, Awareness, Access, and Delivery of Equitable Healthcare. Dr. Wenger, it's such a pleasure, and I'm so appreciative that you would come and to University of Louisville, albeit electronically, and share your knowledge with us this morning.
Dr. Williams, thank you for that very kind introduction. And obviously, Dr. Williams is one of the individuals of whom we are enormously proud as a graduate of the Emory training program based at Grady Memorial Hospital. This morning, we're going to talk about cardiovascular disease in women, and I will address epidemiology, awareness, access, and delivery of equitable health care. For each of these areas, I'll present to you the background information that we all should know, and then highlight the gaps, the knowledge gaps. And for any of you pursuing a research career, this may be a laundry list, if you will, of research projects that you might be willing to undertake to contribute. These are my disclosures. They do not affect my presentation. Next slide. And let's review some of the background data. As Dr. Williams has suggested, cardiovascular disease remains the leading cause of mortality in the US, both for women and for men. And we're all aware that over the recent decades, research identified very important biologic differences between women and men and their responses to social, environmental, and behavioral stresses. But the problem is that the underrepresentation of women in all aspects of biologic research delayed the translation of these discoveries to the care of women. Now, the one message that I would like to share with you is we need a cultural shift when we present cardiovascular health data, both to health professionals and to women, because we identify the characteristics in men as an implicit gold standard, and the presentations in women are termed atypical. They are not atypical. They are typical for women. So let us try to remove that designation of atypical from our lexicon. But importantly, as we will explore, the pervasive gaps, we need to go ahead 2 slides. They went in the wrong direction. One back, please. There we go. The pervasive gaps in knowledge and care delivery for women require attention if we are going to reduce the sex-based disparities and achieve our goal, which is equity in healthcare. Next. Now, the traditional risk factors, we all know, are highly prevalent in US women, but women are not a homogeneous group. There are substantial racial and ethnic differences. And let me just give a few examples. Hypertension is most prevalent in non-Hispanic Black women. LDL cholesterol highest in non-Hispanic white women. Diabetes is highest in Hispanic women. And let me cite for you that in this talk, the designation of Hispanic, the cohort from which this information is derived, is predominantly Mexican American. Overweight and obesity, a major health problem in this country, is highest in non-Hispanic Black and Hispanic women. But even though the prevalence of traditional risk factors is similar for women and for men, we must acknowledge that the control of hypertension, diabetes, dyslipidemia is suboptimal, both for women and for men. And to highlight for you that smoking and elevation in systolic blood pressure are the first and second conventional risk factors that are responsible for years of life lost. Next. Now, what we have not paid adequate attention to, in my thinking, are sex-specific risk factors. And women have specific risk factors, including early menarche, premature menopause, polycystic ovarian syndrome, hypothalamic amenorrhea, hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, high or low birth weight fetus, oral contraceptives, and menopausal hormone therapy. Now, you don't see this in any of our scores, and we will get back to that. And what we see is that there is in this country concurrently cardiovascular health that is less in pre-gestational and in pregnant women than in other women of comparable age, and there's an increased risk of adverse pregnancy outcomes. We've all heard the problems of maternal mortality in this country, but what has not been adequately emphasized is that these problems decrease the cardiovascular health of their children as well. So the problem goes on to the next generation. Next. Next slide. Now, what about clinical cardiovascular disease? And now I'm going to go beyond just the coronary because it's important to realize the spectrum. Nearly half of all women in this country have cardiovascular disease, if we include hypertension among the cardiovascular problems. But there's a greater prevalence of coronary disease, heart failure, and stroke in non-Hispanic Black women. Women in general have more ischemia with non-obstructive coronary disease, that is microvascular disease of vasospasm, and more myocardial infarction with non-obstructive coronary disease than do their male peers. Women have a major excess of spontaneous coronary artery dissection. And even though the prevalence of stroke is comparable for women and men, women have greater mortality and greater disability once a stroke has occurred. Peripheral artery disease more common in women than men, and there is significant associated morbidity and mortality, some likely due to the fact that women tend to receive less therapy with evidence-based medications. Now, for both women and men, what we have seen in this country is a decelerating decline in cardiovascular mortality. The last 2 decades, it had been rather abrupt. Now it has leveled out, and heart failure mortality tends to be increasing. Next. Next slide. Now let's talk about risk prediction and prevention. And every day we all use the quantitative risk assessment tools that include age, sex, race, total cholesterol, LDL, systolic blood pressure, antihypertensive therapy, history of diabetes, and smoking. That's what goes into this risk assessment. And we use it to make decisions about the primary prevention of atherosclerotic cardiovascular disease. But the question I would like you to think about is, are these data applicable to diverse racial and ethnic groups? They were derived primarily from Caucasian cohorts. Importantly, social determinants of health are not captured at all in these assessment tools, nor are pregnancy-related factors and issues of chronic inflammatory disease. Now, particularly germane to when you think about risk assessment in women, in our more recent guidelines, many of these issues are called risk enhancers. But that may not be a good term. It suggests that these matter less, but they may be a predominant problem for the women in your practice. And what I see is we must integrate women's specific risk factors in our quantitative risk assessment tools and scores. Next. Now let's talk about prevention. Prevention interventions are grounded actually in a healthy lifestyle. And what we have are the new AHA's Life's Essential 8 metrics. Remember, we used to talk for years to talk about the simple 7. Now we have the essential 8. And what are these? Non-smoking, no secondhand smoke, a lower BMI, more than 150 minutes of physical activity a week, a DASH-style eating pattern, non-HDL cholesterol below 130, blood pressure less than 120 over 80 millimeters of mercury, fasting glucose under 100 or hemoglobin A1C less than 5.7. And the new and the eighth item added is about 7 to 9 hours of sleep each night. And just think of your last week. Have you attained 7 to 9 hours of sleep each night? I would think not. Now, the other feature that we know is cardiovascular health is poor in young women overall. And that by young women, I'm defining those 20 to 44 years, but particularly during pregnancy. What we see is that the cardiovascular health during pregnancy is less than in comparably aged non-pregnant women. And it's especially poor in non-Hispanic, Black, and Mexican women. Now, when you see a patient with gestational hypertension, appreciate that this increases women's cardiovascular risk, both for coronary disease and for heart failure. And another variable I'd like to bring up, and one that you see in your practices each day, is that there are increased disparities with rurality. Maternal mortality is higher in rural areas. And we will come back to talk about issues of rurality in a moment. Next. And therefore, when we think about prevention, it's really not that simple because it has to reflect intersectionality. We see as progress that women met physical activity goals more in 2018 than they did 20 years ago. But it's only 20% of women. And nearly half of the women don't meet the aerobic activity and muscle strengthening guidelines. But even among this group, the disparities are notable among women. 55% of non-Hispanic white women, 40.5% of non-Hispanic Black women, and 43.2% of Hispanic women. Now, as we see patients, and I'm particularly cognizant of income working in a safety net hospital, there is an association of income with meeting physical activity guidelines consistent with adherence by the social determinants of health. Do these patients have access to areas for safe physical activity? Next. So what then are the knowledge gaps and research needs for the epidemiology and prevention sector? We have to develop and deploy risk calculators that incorporate sex-specific and sex-predominant risk factors. We need cross-disciplinary research in social determinants of health because that is necessary to design the interventions that can address these determinants. We have to define and implement cross-disciplinary interventions. And this shows us that healthcare is not solely a medical issue. It involves communities, health systems, business, urban developers, economic researchers. We have to adopt and implement those risk interventions that embrace intersectionality and that show cultural sensitivity. And importantly, this must be a lifetime approach to risk management and prevention, essentially cradle to grave. Next. Let's now address a very different spectrum, and that is the awareness of cardiovascular disease in women. Are women aware that cardiovascular disease is a major health challenge? Since about 2004, there have been advocacy campaigns by the National Heart, Lung, and Blood Institute and the American Heart Association designed to increase awareness of cardiovascular disease in women. Back in 2009, as a result of these campaigns, the awareness was increased from 30% to 56%. But when we examine these data once again in 2019, just pre-pandemic, there was a 74% decline in awareness among women that cardiovascular disease was their leading cause of death, and the awareness was least among younger women, Hispanic, and non-Hispanic Black women. As a matter of fact, in the same questionnaire, fewer women recognize common heart attack warning signs. If they don't recognize the warnings, they will not come for emergency care. And the recognition was least among younger women. As you know, MI mortality quite high among young women. Next. So education of health professionals is needed to improve awareness because the clinician must know the risk factors for women and the course of cardiovascular disease in women. That's the need, but what are the facts? 70% of postgraduate medical trainees reported they'd had no or minimal sex-based medical concepts during their training. And 22% of primary care physicians and almost half of cardiologists felt well prepared to assess cardiovascular risk in women. This is where the risk is assessed, and these physicians do not feel well informed and trained. And what we need actually in our clinical practices, and we have this at the Emory University School of Medicine, I hope you have it at Louisville, is collaboration between the OBGYNs and the cardiologists to improve the care for women. Because for many ostensibly healthy women, their primary care provider is their OBGYN. And what we tend to see among the clinicians, the non-OBGYN clinicians, is that there's a lack of awareness of pregnancy-related cardiovascular risk. And very often in our electronic medical records, the OBGYN record and the remainder of the medical record are not combined. And I always tell my patients to bring their OBGYN records to their primary care physicians. Next. Now, the awareness data that I've just shown you identify that we lost a decade of progress. Our benefits and gains went down from 2009 to 2019. And what we have to do is to target younger audience through what is now available to us, but was not that available in 2009, and that is the social media channels. American Heart Association has the Research Goes Red registry. And what that registry is designed to do is to achieve awareness, engagement, scientific contributions that reflects a real world partnership between women and researchers. And this is a database that you can access for some information. Next. So then for awareness, what are the knowledge gaps and what are the research needs? We have to identify and implement how can we lessen the decline in awareness among women that cardiovascular disease is their leading cause of death. And these approaches must be culturally sensitive for specific racial and ethnic groups. But at the same time, we must educate healthcare professionals, us, about specific intrinsic and extrinsic age-specific risk factors that are needed to recognize and treat our women patients who are at risk for cardiovascular disease. Next. Now, access to and delivery of equitable health care. And this is probably one of the major challenges of our generation. Let me give you some background information. The access to affordable insurance coverage and out-of-pocket costs affect healthcare access and use for women. I was not aware before I examined these data, and I would like to share these with you, that more than a fourth of US women spend $2,000 or more annually on medical costs. And about a third report that they skip medical care, particularly due to costs. Now, the Patient Protection and Affordable Care Act, Obamacare, gave us the largest coverage gain for women in the 19 to 64-year-old cohort. And the percentage of uninsured women after ACA was 31% lower in 2018 than it had been in 1984. Now, medical expansion of ACA will have a beneficial effect on healthcare coverage and use, particularly in low-income women of reproductive age who are at major cardiovascular risk for maternal complications. Next. Now, I promised you I'd go back to rurality. Women in rural America have a greater cardiovascular risk than their urban sisters. And this additional risk probably reflects less access and poorer healthcare system delivery in rural America. And what we've seen, and the data that I would like to share with you, is that there has been an increase in the life expectancy gap between rural and urban areas. It was about half a year in 1971, it was 2 years in 2009, and it's now more than 2 years in 2014, which is the last year for which we have good data. And I'm sure you're aware, based on your community, as I am of mine, that hospital and outpatient facility care, clinician supply, insurance coverage, and the public health infrastructure in general differ between rural and urban America. And this was exacerbated by the COVID-19 pandemic and its effect on the healthcare systems. And the COVID pandemic taught us a lot about the differences between rurality and urban care. Next. Next. Now, a higher percentage of women than men delay medical prescription and dental care because of costs. And it's not surprising that delaying care delays diagnosis and delays optimal preventive care. And for the woman who delays and forgoes care, there is likely to be more adverse outcome after an acute cardiovascular event. Now, even though, as we well know, there is a lower prevalence of myocardial infarction in women, there are major disparities in treatment, care, and mortality. And women have greater mortality after coronary interventions and coronary bypass surgery, in addition to their increased mortality after acute myocardial infarction. Next. Now, more background information. Women with non-obstructive coronary arteries, when they have myocardial infarction, it is more frequent than in men, almost double in the setting of non-obstructive coronary disease. And as we all know, obstructive coronary disease is the typical presentation in men. MI mortality is significantly higher in women than in men, but particularly among the younger women. Now, interestingly, when there's an acute coronary syndrome, women below 65 years of age have longer daughter balloon times, and there is no treatment gap for the older women. Our perceptions are that coronary disease is an old lady's disease, and don't pay attention to the young women, and that may be a contributor to their more adverse outcomes. Now, when we examine physician recommendations for cardiac cath, given the identical clinical history, compared whether the patient is Black or white, women or men, women and Black patients are less likely to be referred for cardiac catheterization. Next. Now, it's not just coronary disease. We have important information for the Get With The Guidelines heart failure registry. No major difference between women and men in this registry, but the women were more likely to be treated in those hospitals that had a higher proportion of Medicare, Medicaid dual eligibility. And that category of hospital across the nation has an association with poorer outcomes. Women with heart failure less likely to receive an ICD, given the identical clinical scenario. Women who have mechanically assisted circulatory support have greater mortality than their male peers, and to progress on to stroke, the Get With The Guidelines stroke registry, women are less likely to be transported to the hospital by EMS. They are less likely to be imaged within 25 minutes and less likely to receive lytic therapy within the recommended 2 hours. So should we be surprised that women with a stroke are more likely to die within 30 days after a hospitalization? Next. So in the prior format, identifying the knowledge gaps and the research needs, what we have to figure out is how to best assist women to overcome the medical cost barriers that cause them to delay healthcare and prescription drugs. And we need that research if we are going to effectively change our healthcare policy. How can we best improve the knowledge gap, education, and awareness of healthcare professionals regarding female-specific and female-predominant risk factors? Now, I think there is also important data to be gained examining the COVID-19 pandemic, because during the pandemic, we saw effects of increasing economic, social, and family demands on women at all levels. And what effect has that had on their health care and on their cardiovascular health? And probably a major challenge for all our hospitals is how can we improve the efficiency of operations and patient flow and discharge and admissions for elective surgery? Women are more impacted by problems in the efficiency of operations in the hospital, and technology most certainly can help. Next. Now, remember I said there is a need for research data and that women are underrepresented in research studies. What we have to do is to use available standard nomenclature so we can harmonize data across the studies. If we use a standard nomenclature, we will acquire greater statistical power to examine the small numbers of studies with women, and particularly women within underrepresented groups. Now, it's likely that if we have some standard nomenclature, AI and machine learning can accelerate the understanding of those factors that regulate cardiovascular risk in women. We must have an expanded use of social determinant of health indicators in the electronic health records to understand how external factors, environment, social, structural determinants of health modify risk over time. I don't know whether you are aware, but the Joint Commission that accredits hospitals now requires that your electronic health record includes structural determinants of health. So go back and look at your EHR and see all the structural determinants of health there. They better be there when the Joint Commission next arrives. Now, interestingly, a traditional approach in acquiring data has been to look backward and capture longitudinal data trends. But that doesn't enhance progress. What we must address is a looking forward mechanism, finding out how could we sample trends from large data resources to see what is going on now, because that can aid in addressing awareness. Next. Next. And finally, let me give you my call to action in this year, almost ending, of 2022. First, I expect we need culturally sensitive, with appropriate translation, awareness campaigns that will identify cardiovascular disease as a major health threat for women, and emphasizing the benefits of prevention, because 80 to 90% of cardiovascular disease is potentially preventable, and the benefits of lifetime health optimization using Life's Essential 8 cardiovascular score. But we do need interdisciplinary collaboration between the cardiologists, the vascular neurologists, the primary cares, the OBGYNs, to improve the recognition of women's cardiovascular risk lifelong, to implement holistic risk reduction strategies, to educate about the risk factors that either specific or predominant in women, and to get risk calculators with quantitative measures of risk across the life course that can be used in childhood, adolescence, by the OBGYNs during the reproductive years and at primary care visits. Next. All of us must advocate for basic translation of clinical population and implementary research on cardiovascular disease and stroke prevention and treatment in women of all ages. But the focus should be on an under-resourced population. and to emphasize that there are high reward opportunities for lifelong improvement in cardiovascular health. Now, for our basic science colleagues, be sure that animal studies include female animals. Female animals in the animal lab are more expensive than male animals, but we need to include them. We have to ensure that basic science and omic-related studies use and compare female and male single cell lines, stem cells, organized. And then for the clinical trialists, augment the participation of diverse populations in clinical trials. And where this diverse population is lacking is that there is far less participation of younger women and elderly women. The middle-aged women are doing reasonably well. Next. We have to engage communities to optimize cardiovascular health across the life course. We can start with school-based programs because that will involve patients and empower families. We have to meet the underrepresented groups where they are in our communities. I think you're all aware of some of the benefits of partnerships with communities of faith and barbershops and other groups. If there was a pharmacist in the barbershops that were frequented by African-American men, the men in those barbershops were likely to have better blood pressure control. Now, for the women, we need to go into the hairdressers and the nail salons. We have to engage departments and schools of public health to integrate public health and primary care. And then we have to advocate for public policy and legislative intervention with a focus on the social determinants of health. Specifically, access to healthy foods, safe spaces for physical activity, clean indoor and outdoor act, and access to high quality care for prevention and treatment. Next. We use surveillance systems to see how we're doing and to assess our progress on cardiovascular risk factors. And that progress should provide feedback to the key stakeholders in the group. And then lastly, leverage innovative digital technology to capture the metrics for prevention, outcomes, and care delivery. And as I've suggested, the AHA's Research Go Red is uniquely positioned to track life course events. Next. This is my final slide. And per the central illustration that we do in medical publication these days, you see that what we have to do is a very large challenge: raising awareness, optimizing prevention and clinical care, supporting research, engaging communities, advocacy, and certainly to monitor progress. This is all needed if we are to reduce the risks and burdens of cardiovascular disease in women. And I thank you for your attention, and I welcome any questions or challenges. Thank you very much.
Thank you. Go ahead. I'm going to say, Dr. Williams, go ahead. We'll let you kick off.
Thank you so much, Dr. Wenger. My comment is actually, or my question is actually, to start off, taking the chair's prerogative, is a bit of an accolade and a comment and a question all in one. Obviously, you've been focused your entire career on women, but there was an underlying theme throughout your talk of the rural economic and ethnic differences that accelerate heart disease and its risk factors. And of course, with my interest in nutrition and healthcare disparities, they do intersect. And you mentioned the importance of prevention and healthy food. Now, the sensitive part of my comment is that I remember as a Emory Grady graduate, getting there as an intern and seeing the twice as many water fountains and twice as many restrooms and twice as many cafeterias. And I know that you were one of the core people who changed the system so that the white-only signs were actually removed. And I really want to, that's the accolade. I just want to publicly thank you for everything that you've done to try to help more racial equality in healthcare. But then the twist to it was that I found interesting as an intern was that everyone flocked to the Black cafeteria. That is, the signs had come down, but the diet between the cafeterias did not change. And there you had the pork chops and the fried chicken, and instead of yams, you had candied yams. And these differences actually continue today. And it's so important to talk about the leadership of women in terms of diet. They determine what's bought and what's cooked in the home for most of us. How can we do all the things that you said on your action slides? What kind of programming can we come up with? And obviously, I'd love to hear any of the stories that you like to tell about how things got changed at Grady Hospital. And maybe that becomes a roadmap for how we can change it, and other areas where our economically deprived people, particularly rural, are underserved as well. So it's a sort of a two-phase question. The societal part, yes, but also the understanding that women play such a critical role in nutrition and health in their families.
Well, at Grady Hospital, we have a fascinating program called Food as Medicine. And in the area near the parking deck, where there used to be a McDonald's, we've gotten rid of the McDonald's, and we now have a food market that either sells at low cost fresh fruits, vegetables, etc., or for patients with prescription, gives them these foods and vegetables over a period of time. Coupled with this, there are cooking classes and tasting classes. Now, if you're going to suggest to a patient a food that is not usual, with spices or other areas that are not familiar and almost non-pronounceable to many people, give them a taste. If it looks and tastes comparable to the food they're used to eating, they will try it. And this is part of what we're doing. And some of this actually was incorporated in the President's Conference on Food and Health just a couple of weeks ago. And we have to begin to think of food as medicine so that it's our responsibility. Kim, I think I told you many years ago that I learned a great deal from Dr. Bill Cannell, who was the father of the Framingham Heart Study. And Bill said, he said, I've always wondered why physicians don't talk more about lifestyle issues. And, essentially during this 15-minute visit, physicians feel uncomfortable talking about things that the patient's mother-in-law would have told them for free. Well, I think that what we have to do is to assume the role of the mother-in-law and make patients realize how important lifestyle is as a component of their health care.
Well, thank you so much for that. And I'm glad to see that things are progressing and in such a way that you actually have programs that we can model around the country to get healthy food and healthy food concepts. You mentioned education. Let's open it up to the audience for questions. So Jason, you usually have a handful that are coming through the chat.
Yeah, we actually have two right now. And anyone, if you can post it in the chat area, or you can unmute and ask. Well, first we'll start. We have a question from Dr. Christine Kruger, who's our academic chief of gastroenterology and our former interim department chair. And she wants to know, says, do you think the normalization of increased body mass coupled with increased technologic sedentary activities, such as iPhones, more young women playing video games, should be formally addressed as predictors of heart disease, DM, metabolic and metabolic syndrome? Says even grade schools have removed playgrounds for fear of liability, and young women are not taught to exercise or eat healthily in most public schools.
Well, again, you model what you learn in school. And when school cafeterias serve healthy foods, they're likely to be accessed by the children in non-school settings. But when we remove physical activity from the schools, it's no longer viewed as being an important component of education. So I think it's very important that we, again, address the life's essential 8. And rather than saying, don't do this, to say what you should be doing. You should be eating a healthy diet. You should be exercising. Smoking behavior should not even start and should certainly stop. But we have to model it in the schools for the young women to access this.
All right, we have another question, and this comes from Dr. Stephen Winters, who is our former chief of endocrinology. And he wants to know, how do you reconcile the increase in CVD that follows bilateral ovariectomy in young women with the increased CVD risk of estrogen treatment in older women?
Well, again, we know that estrogen has a very protective effect on the vasculature, and you see this with intrinsic estrogen. For many decades, we inappropriately transferred that data to menopausal hormone therapy, which was thought to cure everything from wrinkles to dementia. And now we realize that it does not improve overall cardiovascular health. So certainly it is good therapy for menopausal symptoms, but not for cardiovascular health. But we still have a great deal to do for the younger women in terms of making them realize that they are not completely protected by their intrinsic hormones, and certainly for postmenopausal women, that menopausal hormone therapy treats menopausal symptoms, but not cardiovascular health.
All right, and those are two from the chat area. Anyone that, if you like to post a question or if you want to ask a question, please feel free. We've still got a few minutes. Dr. Wenger will be very happy to answer your questions. Or if Dr. Williams, do you have any follow-up questions? I'm sure you have a few.
I did. You know, I just remember hearing some of the stories, Dr. Wenger, about the time in the past where you were fighting for justice, not just for women, but for the poor and everyone. I didn't know if you wanted to share some of those stories with our audience, but they were just lovely to hear. And with or without the stories, again, I just want to thank you for everything you've done throughout your career.
Well, you know, the important feature, and I think for all of us who are interested in women's health, in particular women's cardiovascular health, I expect there are 4 steps that I have shared with women and with the advocates. The first is investigate, get the data. The second is educate, transfer that data to the information for women and their health providers. The third is advocate, because advocacy is very important. And the last, very important, is legislate. The Healthcare for All and Research for All Act of a few years ago increased the number of women in clinical trials, increased the use of female animals in NIH research studies. So we need this 4-step process of investigate, educate, advocate, and legislate. And all 4 of them are important, and they really go in series.
Well, I really appreciate that. You know, I did, when people ask what I would like to do as a chair, and I always talk about the 5-tool physicians, and not just being a good clinician or and master educator and a prolific researcher, but understanding the administrative side of medicine, and most importantly, advocacy. We have so many opportunities to get to have an impact on our regulators and our legislators, both at the state and federal level. And I hope everyone is hearing your message and takes us up on that going forward.
Well, again, you know, all of us are really privileged. We are privileged by our education, by our information, by our trust with the general community. And as privileged individuals, we have the privilege to give back. And that should become a personal responsibility. And in our area of knowledge, in our specialized skills, we should be giving back to our communities regarding health, and for my area of interest, cardiovascular health.
No, absolutely agree.
We do have one, I was gonna say, we do have one more question from the chat area, if that's okay, Dr. Williams. All right, it's from a Dr. Priya Krishnan, who's one of our physicians out at our Louisville VA hospital, and she wants to know, she asked, the hardest thing for lifestyle change to healthy habits is socioeconomic status. Healthy foods have become quote unquote boutique and are out of reach for a huge percent of the population. Additionally, it's not easily available. She wants to know, how were you able to overcome these challenges at Grady?
Well, again, we've started to do this with our Food as Medicine program and our food bank, if you will, and our classes are adjacent to the hospital. So that we started small. We started with prescribing it for patients with particular needs, and we hope to be able to expand it. Obviously, this requires funding. And I think if any of the federal programs go through, we should be able to do this as part of an outreach service of a hospital or medical center. As a matter of fact, even on the Emory University campus behind the hospital, there are each week the equivalent of farm to market stands and stalls, and they are packed both with professionals and with students. And this is the beginning of instilling a habit of healthy living. It's bringing the food to where the people are for busy students and for busy health professionals. And do you have one of these at your hospital? Can you get them? Can you work with some of your local markets to see if once a week they'll come on to the campus and have particularly healthy and reasonably priced fruits and vegetables and so forth?
Well, thank you for that. And actually we do. It's associated with our Traeger Institute for Aging, but it would be nice to bring it to the hospital and spread it around because it's such an important issue. You did mention, I was pleased you did mention the White House conference that happened on September 28th. I was pleased to be one of the people giving recommendations, and I was even more pleased to hear the administration give credence and say that they intended to do a lot of the things that we were recommending, including in this regard, changing the SNAP program so that you can get more of the healthy food than you can the unhealthy food. And that these are the kinds of things that, plus the community education. It would be nice if they were to change some things like the congressional subsidies for healthy versus unhealthy food, which they say they will do. But I think we can go a lot further with the kinds of programs that you're mentioning at the neighborhood level. All right, Jason, is that it looks like we've covered everything. Well, again, I just want to sum up by thanking you so much, Dr. Wenger. There's very few people, your parents and some of the teachers in school, but I have to be very honest and say that I wouldn't be sitting here as chair of medicine at University of Louisville if it hadn't been for your influence. So thank you so much for all of the insights and for your entire career of all the things that you've done for us.
This was my pleasure. And given the pandemic subsidence, perhaps one day I'll be back at Louisville to lecture in person.
Well, we certainly look forward.
I was going to say, we have one real quick. We have something for you, Dr. Wenger, and it's something that's very synonymous with Louisville. It's a gift we like to give our visiting speakers, and especially for our named lectures. So, and just won't be too long, you're going to get your own personalized Louisville Slugger bat.
Oh, that's going to be wonderful to keep my trainees in line.
we hear that a lot. Well, but we'll get in touch with you about where you want it shipped and exactly. But I'll get back in touch. But thank you again, and thank you, Dr. Williams, for facilitating such an outstanding talk. And we really do appreciate it.
Okay. All right, so we'll let everyone.
Thank you all, and have a good day.
All right, Dr. Wenger, what we're going to do, give me 1 second, let me stop our recording.